Hello and welcome to HealthLine this Tuesday evening. I'm Jennifer Blomquist. I have the privilege of hosting the show tonight, and I'm so glad you joined us. If you're one of our regulars, you know the deal. It's a live show. That's why we have a phone number up at the bottom of the screen, so you can call in and ask a question anytime between now and just about 8 o'clock. We have an orthopedic surgeon with us this evening, and we are going to talk about shoulder arthritis. But if you have anything else orthopedic related that maybe you just want to get a little advice on, or just have maybe an idea of what you should do to handle your situation, please give us a call. Again, it's 969-2720. In case you're outside of Fort Wayne, it's still free. Just put an 866 in front of there, and it will be a toll-free call. And when you call in, you have two options. You can either ask your question live, which is great because then the doctor can interact with you, maybe get some more information from you that will help him to better answer your question. Or I completely understand if you would rather just talk to the call screener, relay your question to her, and then she can relay it to me, and I'll ask the question for you. Either way, you'll get your question answered. So let's go ahead tonight and meet our guest. This is Dr. David Connor, who is an orthopedic surgeon. Thanks so much for coming on.
Good evening.
Appreciate it. And he brought some, well, they're not really toys. I guess we'll call them props, but models, yes. And so that will help a lot, because sometimes, like for most of us, we don't really think about what our shoulder looks like on the inside or what a surgery would involve. And so these instruments will help us to better understand. So like I said, call sooner rather than later. Sometimes we get a little backed up toward the end of the show. We'd hate to miss your call. So phone lines are open now. We're going to go ahead and start talking about shoulder arthritis in the meantime. So everybody is familiar probably with what arthritis is, but maybe not so much shoulder. You know, I always think of it in the knees and,
Sure.
and fingers.
So arthritis is a very generic term that we use basically to mean any kind of damage to cartilage surfaces within a joint. So specific to the shoulder, there's two main parts of the shoulder. The ball portion of the top of the humerus, which we call the ball is the humerus, and then the cup portion is called the glenoid. And so there's really, in orthopedics, there's two main types. The first type that most people are familiar with is osteoarthritis, or basically, for lack of a better term, the joint wearing out. And that can occur from multiple different reasons. People with chronic rotator cuff tears, people with just overuse injuries or traumas, those are basic types of osteoarthritis. And then this another type that other people are familiar with are basically rheumatoid arthritis, or autoimmune type arthritis, where the body kind of attacks itself and for lack of a better term, destroys the joint surfaces. So those are the two main types that we treat within orthopedics. Yeah.
So does it tend to start at a certain age, or do you find that it's more prominent in men or women, or does it really just run the gamut?
Yeah, so we see that in both men and women. Statistically, I think I see a little bit more in women than men, but it's not a hard and fast rule. Men tend to be kind of people who've done a lot of manual labor their whole lives. I see those more kind of in their late 50s, in the early 60s. Women tend to be a little bit later in life, into their 60s and 70s. And that's when we they tend to appear. But as far as all males or all females, it can be seen in both groups.
So I know just from having many of your colleagues on over the years, the philosophy has always been to start as conservatively as possible. I think that's what some people are afraid. I'm going to go see a surgeon. He's going to want to throw me into surgery. But so what is the approach you would take with somebody? Maybe they're having some pain.
Sure.
So where do you even begin?
Yeah. So the conversation I have with all patients is that treatment starts in two big categories. Okay, so category one is always non-surgical type treatment. So non-surgical type treatment can include, medications, a lot of medications that we're all familiar with: Tylenol, ibuprofen, Aleve, anti-inflammatories, those kind of things. Also physical therapy, making sure that the joint stays in motion. That physical therapy can be with a physical therapist. It can also be just simply doing exercises at home. As you get a little bit more involved in the non-surgical type treatment, that can involve interventions such as injections, a lot of which we can do in the office. And those injections are typically steroids. Those steroids are meant to basically put a dose of anti-inflammatories directly inside the joint. Those injections are not meant to actually cure the arthritis. There aren't good injections out there that actually cure the arthritis. The injections are meant to help alleviate the pain, but the pain is really the problem. A lot of people, I look at the x-rays and I say, gosh, we have a problem, but people aren't worried about their x-rays, they're worried about how they feel. And so
Sure.
if we can make their arm feel better without surgery, then obviously that is always our goal.
Can you pretty much diagnose it with just an X-ray, or do you have to do something more involved, like a CT scan?
For the most part, no. We always start with simple X-rays. X-rays give us a ton of information about, how bad is the arthritis, how long has the arthritis existed, and then it already starts shaping our treatment options as far as what are we going to do, how far along is the arthritis, and then kind of guiding us. If we decide to do something surgically, then it starts guiding us towards, one type of surgery or another. Yeah.
Now, with the injections, is it kind of like, I've heard of some people with some orthopedic issues will get an epidural and it will tie them over.
Yeah.
I've met some people that say they can go months.
Yeah,
is that kind of what these other injections, could you stave it off for a while?
Absolutely. As we give injections as frequently as about every 4 months, but I've seen people get relief up to 6 months, 9 months of relief from the injections, and that's something that we can repeat. There's no hard and fast limitations to injections. Obviously, we don't want to do too many injections too close together. There are some detrimental effects of giving too many injections too close together, but if you've gotten an injection, you've got 6 months of relief, you come back, get another injection, get 6 more months of relief. That doesn't, there's not you've reached the magic number of 3 or 4 and now you can't have any more. Now, with injections, it tends to be the law of diminishing return, in that each injection tends to help a little bit less, but there's not an actual 3 or 4, you've had too many.
Okay. So, at some point, if you're doing injections, like you said, it's not going to cure it.
Yeah.
Is it kind of just putting off surgery in most cases?
But also when we're talking about arthritis, when we talk about the treatment of arthritis, a lot of times that involves putting a special type of joint replacement inside there. When I talk about joint replacements, when I replace people's joints, I tell them, hey, I'm handing you the keys to the last car you're ever going to own. So you got to kind of take care of it.
Take it easy, yeah.
Meaning that, this implant that we put in people has a shelf life. So obviously, if we can push off doing that implantation, that's helpful for you, so that you can get as much longevity out of this implant as possible.
Sure. All right, well, and I want to remind everybody, we have not received any calls yet, but we'd love to hear from you. We're talking about shoulder arthritis with Dr. David Connor, and that's why we keep that phone number at the bottom of the screen for you so that you can call us anytime. It's 969-2720. Again, it's still a free call if you're outside of Fort Wayne. It's just an 866 that you put in front of there. And again, you can call and ask the question live, or you can relay the question to the call screener, and we will ask it for you. So please feel free to give us a call at any time. If you get to the point where surgery is really the last option, are there even different types of surgeries that you would do?
Absolutely. So there's two, when we talk about shoulder arthritis, there are, within orthopedic surgery for shoulders, there's basically 2 main types, and then within that second type there's a subgroup. So the first type would be arthroscopic surgery, and that would be minimally invasive surgery where we go in with a couple of little poke hole incisions, and specific to arthritis, we can go in and basically clean up some of the damage, release some scar tissue, and help with the mobility and help with the pain inside the shoulder. As we get out of arthroscopic options, then the second option then becomes what we technically use the term arthroplasty, and what that means is joint replacement. So within shoulder replacements, there's 2 main types of shoulder replacement. The first type is what we consider an anatomic shoulder replacement. What does that mean? That means that in the situation, and we can see a model here, is that we replace the ball with a metal ball, and we replace the socket with a plastic socket, okay? In this situation, that eliminates, this implant eliminates the arthritis on the ball and on the socket, and but this implant requires that all of the rotator cuff tendons, which you don't see in this model, but I can put my finger here and here, that's basically where the rotator cuff tendons lie. When those are intact, that's when we do an implant like this, or what we call an anatomic shoulder replacement. The second type of shoulder replacement, we see a model over here. The second type of shoulder replacement is what we call a reverse total shoulder replacement. In this situation, we reorient the ball and socket. We put a ball where the socket is at, and we put a socket where the ball is at. And the reason why we do that in this situation is when people have damage to the rotator cuff tendons. The damage to the rotator cuff tendons necessitates that we change the anatomy. And both of these implants, the goal is to remove the arthritis. The biomechanics change a little bit when we use these types of implants so that we can help the patient alleviate their pain and function better in the future.
Is one of them, are they both fairly invasive surgeries if you get to this point?
Yeah, I mean, this is for shoulder surgery, this is about as invasive as it comes. Okay. It involves making an incision over the front of the shoulder, typically, I would say somewhere in the 6 to 8 centimeters range.
Okay. Yeah.
And we have to obviously move some of the structures around, move some of the anatomy out of the way. The shoulder replacement surgery itself typically is a one-night stay overnight in the hospital, and then does involve some physical therapy afterwards.
That's what I was going to ask you about the recovery, because I'm always amazed when we have the guys who work on hips and things, and they'll say, "Oh, my patient's standing, that night after a hip replacement." I'm still amazed, even just one night for something like this. Seems amazing. I mean, do you have to keep it immobilized for a while? Or?
Yeah. So depending on the type of the shoulder replacement, for the anatomic shoulder replacement, because of the anatomy, we start physical therapy pretty quickly after surgery.
Okay.
We'll start within a couple of days. Most people are in physical therapy somewhere between 6 weeks and 10 weeks, just depending on how the recovery process works. With the second type of shoulder replacement, or the reverse shoulder replacement, that's a situation where we don't start physical therapy for another 4 weeks afterwards. In my situation, we let a lot of the soft tissues heal before we start physical therapy.
And I know I've heard the comment before, especially for people maybe who've done a lot of manual labor for the bulk of their career. I've had some of your colleagues say, I tell patients, I can't turn back the hands of the clock. I can't. You may be 50. This surgery is not going to turn you into the way you were at 25. So, I mean, at this point, if somebody's having this kind of surgery, it eliminates their pain, but do they tend to have the same amount of mobility with their arm or usage? Could you still lift?
Yeah, absolutely. So for the first surgical option, these are implants that get about as close to normal anatomic motion as you can get. Okay. There are some limitations as far as how much you can lift, but typically most of the limitations that we put on people as far as overhead lifting and things like that, these are amounts of weights that most people in these types of situations aren't lifting to begin with.
Okay.
Generically we say about 20 to 25 pounds overhead after this type of procedure. With the second, it's similar to the second type, which is the reverse shoulder replacement. The limitations with that, you do sacrifice some motion with this type of shoulder replacement, but the upside is that it's I would say a more reliable implant, in that most people who are getting this shoulder replacement likely aren't going to need more surgery in the future.
Okay, all right. And everything is probably kind of a custom thing. I mean, I imagine there's not really like a cookie cutter formula. Every patient is unique.
Absolutely.
Well, we do have somebody who wanted to ask you a question, Dr. Connor. So we're going to go ahead to Judas. Are you still there?
Yes, I'm still here.
Oh, go ahead. Thank you for your patience. Go ahead with your question.
What I wanted to know, I have rheumatoid arthritis. I have a torn rotator cuff. I've already had shot, and I've already had physical therapy. I'm kind of just holding my own. So I just wondered what my next step would be. I'm 77 years old.
Yeah, so certainly, in this type of situation, you are exactly what we're talking about here. You are in the exact kind of age demographic and function demographic that we're talking about. As we start treatment, all patients with me tend to start with injections and physical therapy, but right now, the only person in the equation between the doctor and the patient who can really determine whether there is a next step for you as far as surgery is you know, because I tell people all the time, I'm not saving anybody's life by replacing their shoulder. And so, you know, the time to decide to move past what we consider conservative treatment or non-surgical treatment, the time to consider moving past that is really up to you. I would tell you that in this situation, if you say, gosh, I really feel like my function is not where I want it to be, and I can't tolerate the pain, that's when I tell people, okay, it sounds like you are moving towards, you know, you making the very personal decision about moving forward with surgery. But there aren't any hard and fast rules as far as like, oh, you're this age and you've had this many injections and you've tried this much therapy. You know, I can tell patients in this situation, well, gosh, it doesn't look like, you know, another injection or more therapy is going to help you, but really the decision to move forward with surgery is really a personal decision based upon kind of how you feel and how your shoulder is functioning.
Judith, did you want to ask Dr. Connor anything else?
No, thank you very kindly.
All right, well, good luck to you. Thanks so much for calling in. It's interesting. I was going to ask you that question because I've, you know, when we've had other of your colleagues on who do knee replacements, I've heard them say that, you know, the patient will say, well, when do I need to get surgery? And the doctor says, you tell me.
Yeah,
and so it sounds like the same thing here.
Yeah, absolutely. I mean, it's just, you know, so much of this, what I love about orthopedics is that it's, I would say pseudo-elective, meaning that, you know, I'm helping people improve the quality of their life. I'm certainly helping them improve function, but I'm certainly, I wouldn't say I'm sustaining anybody's life. I'm not saving anybody's life by replacing a knee or shoulder or whatever, but it certainly is improving their quality. And really it's a personal decision for the patient to say, my quality of life is so poor, now it's time for me to move forward. So.
Yeah, it's nice when you feel like you have a little control over that kind of situation as the patient. So we have another caller who'd like to ask you a question. John, are you still there?
Yes.
Oh, thanks for waiting, John. Go ahead with your question.
Doctor, I did have a question. I think you may have answered it, but we'll cover it real quickly. But I also have a comment I want to make first. I had a number of bone spurs in my right shoulder. Now, this is going back 10 or 15 years. And it was so painful. I could barely move my shoulder, like not even an inch or two. And I had that shoulder replaced, and I've had no problem since. So I went from incapacitated to useful and healthy again in that shoulder. Well, I'm a few years older right now. And my left shoulder, I was told that I have no rotator cuff in there. That somehow was injured and reabsorbed by the body. But I think you covered part of this. I don't have any pain in it. And my question would have been, would you suggest that I have surgery? And as I was listening to you and the moderator, you were saying that without pain, it's really up to the patient. And what kind of, my reason for hesitation for having surgery is not only the factor of no pain, but also I'm afraid to have surgery and then fall on it. Unfortunately, I'm in more advanced age now, and that's a problem once in a while. I appreciate your time. I hope I haven't wasted it. Thank you.
No, you certainly have. I mean, there's two main reasons why people tend to have surgery. Number one is pain, and number two is function. You know, and if you've answered the first question. So if you don't have any pain, it's hard. I tell people all the time, it's hard for me to take you from no pain and improve on that situation. I can only make you different in that scenario. But the second reason then is function. You know, and so. My only caveat here is as your shoulder starts to deteriorate from function, as you progress, as the function gets worse and worse, even without pain, as the function goes down, I would say as you get to the point where you can't lift your arm off of your body, you can't start, ask people all the time, can you get things off the top shelf? Can you, lift? I would say basic items around the house. As those functions start deteriorating, that's a situation where I would say it's at least time to go have somebody take a look at it, because there are times when I've had patients go from, hey, I can fix this, or I can certainly improve this, to, gosh, sometimes this situation is just too far gone.
John, I don't know if you're still on the line. Did you want to ask Dr. Connor anything else?
Well, I do. Yes, ma'am. Thank
Sure.
you.
Oh, go ahead.
Doc, I do have some loss of function. Like, I can't put my arm straight up, but I can get by with other parts. I mean, with using my shoulder, other parts of the day. I don't consider it incapacitated at all at this point in time.
Okay. Yeah, I mean, and again, it's how much pain is too much pain. That's a personal question, and what kind of function is acceptable is, again, another personal question, where people say, hey, if I can get by, making accommodations to my life, then that's certainly something that is worth waiting on surgery for.
All right, John. Well, it sounds like he's got some decisions to make
For
and
sure.
Contemplate. So good luck to you, John. Thank you so much for your question. So it's always nice when they can interact with you and get the advice that way. So we do have one more call from somebody who
Sure.
wanted me to ask the question for you. So a woman called named Allison. She says her granddaughter has, and I'm not sure how to pronounce this, Ehlers-Danlos.
Ehlers-Danlos. Yes.
Okay, syndrome. Does that ever get better? I am not familiar with that.
Sure. So Ehlers-Danlos is a connective tissue disorder that affects different tissues in the body. Basically, these people with Ehlers-Danlos have what we call hypermobility, or their joints are ligaminously lax.
Okay.
It is a genetic disorder. There are some other problems that can occur in and around the body, but typically the situations that I address are hypermobility, shoulders, knees, and hips. Because it is a genetic disorder, there are treatments for it that address the symptoms of the problem, but there's no pill, there's no injection, there's no thing at this time to actually cure Ehlers-Danlos. Now, I see specifically that she's asking about this problem in her shoulder. Now,
Yeah.
specific to your granddaughter's shoulder, a lot of times kids, and I see a lot of them in the kind of their adolescent, teens to later years, you can see these kids with hypermobility or shoulders that kind of pop in and out of the socket. The beginning of the treatment always for these kids, because they have a connective tissue disorder, the beginning is always physical therapy.
Okay.
So stretching exercises, strengthening exercises to help the body kind of accommodate for the disorder. But as far as, again, a cure for it, there is not a cure. But, if you're specific to your question of does that get better, I've seen lots of patients, specifically without surgery, get significantly better from a pain and function standpoint.
Okay.
with non-surgical type treatment, physical therapy, and over-the-counter medications.
What, do they have a lot of restrictions, children with that syndrome? Or?
Typically not. I mean, obviously if a adolescent teen is participating in a sport where they're sports where they're repetitively injuring themselves. Well, this is where I always remind parents: sports are, elective
Yes.
events. So if your granddaughter was playing basketball and she's dislocated her shoulder 10 times, or participating in gymnastics or other sports where she's repetitively hurting herself, then I would say, hey, it's time to stop
Sure.
these activities. But as far as have I had patients who've participated in football and basketball and myriad of other sports with the Ehlers-Danlos, I would say, they lead relatively normal lives.
All right, good to know. And there are lots of other things to do besides sports, too. Sports are wonderful. Sometimes there's a big focus on that, but there's also band and all sorts of other performing arts type. We were talking about marching band, what a big commitment that is, but it is fun. So sadly, we are out of time. Dr. Connor, thank you so much. I appreciate you bringing the models. That was extremely helpful. And we have a great audience. We always have good callers, good questions. So thank you so much to everybody who called in this evening. And we will have another HealthLine, of course, 1 week from tonight. Mr. Mark Evans will be hosting that program right here. And I want to remind you, if you ever want to watch like little clips of this show or previous HealthLines, they do have that on YouTube. So if you go to our PBS 39 webpage, you can access it there. I'm Jennifer Blomquist. Take care. Have a wonderful rest of your week. And we'll see you back here, or Mark will, next Tuesday. Bye-bye.
Thank you.
The preceding program on PBS Fort Wayne was made possible in part by...
It's a new day at Parkview. Another day to rise up and make life better for those around us. Whether that means pushing the boundaries of what's been possible, taking big strides, or sitting with a patient long after a shift has ended. At Parkview, we don't just do what's expected. We do what's best for you and your family. And we're determined to do it even better tomorrow. Every person, every day. That's the kind of healthcare we believe in. Parkview Health. We believe in better.